quitting of things that contributed to the PAD, which is the risk factors we talked about earlier. So if you're a smoker, you always want to encourage smoking cessation. If they're a diabetic, you want to make sure their blood sugars are under strict control, blood pressure under strict control, cholesterol under strict control. Family history, obviously, you can't change. And sedentary lifestyle, you can change. So you want to encourage them to exercise more.
Mm-hmm. And how often should you follow up with your specialist?
Depending on the degree of blockage, again, usually my patients that are stable, it's usually a 6-month follow-up or a 1-year follow-up. But you really should get, let's say we have patients that have major blockages and we fix them. You can't, you really have to check with an ultrasound is still good. Because we do a lot of work in the periphery, and one thing a lot of the physicians know is that peripheral vascular disease and the interventions, they work, but they don't always last. And you can do a great job. I mean, you can go in there and you can have 100% blockage and you fix it, and it looks beautiful when you're done. But if the patients continue to smoke, or even if they don't, a lot of times the peripheral vascular disease, it comes back. And so that's something that you have to keep a very close eye on.
And now for my favorite part of every topic that we cover, let's bust some myths about PAD. What are the top 3 most common points of misinformation do you hear about this diagnosis?
Probably the fact that it's not that common when it actually is. I could tell you there are millions of people who roam this earth who have severe PVD and they don't know it. So it is actually extremely common. But again, back to what I'm telling you, that it takes a lot sometimes to realize it. And it's such a slow, steady, progressive disease that the patients don't even realize that it's there. And so a lot of times patients that have, and especially those that have complete chronic total occlusions, and their symptoms were not like drastic, but it's there. And so you fix it for them because they did have some symptoms. And they're like, oh, and they can't thank you enough. They said, Doc, thank you. So I didn't realize how bad it was, is usually what they end up saying, because it was such a slow, steady thing that the patients almost got used to it.
Right, and they don't think it's so dangerous because it's a progressive disease. But it could really lead to morbidity, mortality, impact your quality of life.
Yeah, absolutely. And critical limb ischemia and we have a limb salvage program here where we work, and we're very proud of it too. We have vascular surgeons in our group who are really on top of it. And anytime an amputation is required, whether it's a toe or half a foot or a foot, it's very sad. It actually is extremely sad. And this is something that really all providers should kind of unite together to try and work our best to increase screening of PVD and early treatment, which is key.
Absolutely. And I also, just one more point on this, I hear many patients say that it only affects smokers, which of course smokers are at a greater risk, we know that. But how many patients do you see that aren't smokers get PAD?
Yeah, a tremendous amount. And if it's not smoking, it's usually something else that makes up for it, like very uncontrolled diabetes, uncontrolled hypertension. All these risk factors, they all play a role. And so, like I said, just because you're not a smoker, if you have really bad diabetes, it's just as bad. And again, in patients, and especially too, Shannon, I can't stress this enough, patients that are on dialysis, that's a really, really huge risk factor for PVD. And the reason I bring that up is because usually they tend to be severely calcified. And there's a huge difference between soft plaque and calcified plaque, and it can make the difficulty, the complexity, the technicality of the procedure, it changes completely in terms of what tools we use to fix the blockage.
And speaking of tools, what are some of the new technologies in treating PAD?
Yeah, I can tell you, there's a lot that has changed in this field. I mean, since I was a fellow and in my training.
Mm-hmm.
You know, the one thing that in our particular practice that we do a lot of is called pedal access. And that means going in from the foot. It's analogous to the coronary artery disease when we do radial access, right? A lot of younger physicians now, they really, they like to do radial access, which is access in the arm here, as opposed to poking in the groin, because it minimizes complications afterwards, you know, as a hematoma in the groin. It's the same concept with the legs. So coming in through the foot is this technique that most people who treat PAD do not employ. Most people still go in through the groin, but I'm a big advocate of going in through the foot.
Mm-hmm.
But in terms of the actual technologies, like new tools that we have, atherectomy has been a game changer for PVD. See, before you would go in there and you would just balloon it open and say a prayer and hope that it looks good and hope that you didn't have to put a stent in there. And I hate putting stents in people, by the way. You have to sometimes. In the heart, it's a totally different ballgame. In the heart, you almost have to put a stent in because it's such a small vessel. And we've learned over time that if you don't put a stent in, it's more likely to close. But in the legs, when you're dealing with such a large artery, it's best to not leave any metal in there as much as you can. So a new technology that has allowed us to not leave as much metal in people is called shockwave. Shockwave is intravascular lithotripsy. And it's a balloon that gets inflated very, very slowly. And it hooks up to a lithotripsy machine. And when the balloon is inflated, we press the button, and then it allows the balloon to send a signal to sort of break up the calcium in a very non-aggressive way that would minimize the risk of dissection, which would in turn minimize the risk of needing to put a stent. And this is especially important for me in the iliac arteries, because traditionally in the iliac arteries, we would put stents in people. That's sort of what we were led to believe was the best thing to do. So shockwave has been really good at eliminating the need to put stents in people. Another new tool that I'm a big fan of is called the Rotarex from Bard. And this one is very good for chronic total occlusions. Chronic total occlusion is 100% blockage. Before, we would go in there, and Shannon, there was no way to take the blockage out. You know what I'm saying? A chronic blockage, you would cross through it, and then you would take a balloon, and you would squish all that nasty plaque against the wall of the vessel.
Oh.
But this new device, literally allows us to do an atherectomy and pull that gunk out of the vessel. And so I'm a big proponent of it, and I really think more people should use it in terms of chronic total occlusions. It's just so relatively new that it's going to take a while to get the word out. And we also have newer stents.
Mm-hmm. It's so interesting to see the evolution of technology and how this technology itself, of course, on top of the great work of those who are intervening, has really improved patient outcomes.
Absolutely, absolutely. And to be honest, it makes our job easier. It does. The procedures don't take as long. And the tools, they're really good. And I think they're just going to continue to get better. The other thing I was mentioning is that in the stent world too, there's all the stents work, don't get me wrong, but there are some new stents. The one that I am using the most right now is called Biomimics by Varian, and it has a special sort of conformity to it, to where it is less likely to fracture. Because when you're dealing with putting metal in the legs, think about the knee area where you're bending. And so essentially that stent can crack. And that's a big problem because that can lead to almost like a heart attack. It can lead to a leg attack. That's called acute limb ischemia. And that's not something that anybody wants. And so as the stent technology improves, we're seeing better outcomes, and hopefully the patency rates of those stents will be better as well.